السلام عليكم ورحمة الله وبركاته. إن شاء الله هنتكلم we will speak today about cranial nerves. We have 12 pairs of cranial nerves which supply head and neck. This is a diagram showing that which is the 12th cranial nerve and which supply. And this is a character diagram which demonstrates each cranial nerve which supply. We will start by first cranial nerve, which is the olfactory. It's a special sense by olfaction, and it is originated directly from the brain tissue. To test the function of the olfaction, we must examine each nostril separately, and must use familiar non-irritant odor like pepper coffee or orange cedil. We will close each nostril. If we are examine right one, we will close the left and close the eye and ask the patient which he smell. We will not use an irritant or irritant odor, because if you use irritant odor, it will lead to nociceptors of the stimulation of nociceptors of the trigeminal nerve, not the olfaction. Because of that, we must use something familiar and non-irritant. The second one is the optic nerve. It responsible for visual acuity or vision, and it is also originated directly from the brain tissue. To test the optic nerve, we must examine the visual acuity by counting fingers in our case. But if we need sophisticated, we must send to the ophthalmology and use the eye chart. Examine the visual field also. In our case, in neurology, we use the confrontation method. But if we need a sophisticated one, we send to ophthalmology. In case of poor visual acuity, we'll be using flashlight instead of finger. Also, one of the tests of the optic is the fundus examination. These, as we said, olfactory and optic nerve originated directly from the brain tissue. But the other cranial the rest of the 10 cranial nerves are originated from the brain stem, from midbrain, bones, and medulla. The third one is the oculomotor. This supply all muscles of the eye, extraocular muscles of the eye, except lateral rectus and superior oblique. The superior oblique are supplied by trochlear nerve, and the lateral rectus supplied by the abducent nerve or sixth nerve. Because of that, we must test the cranial nerve, extraocular movement, third, fourth, sixth nerve together. In case of that, we use the H shape. This is the X cardinal direction of gaze of the extraocular movement, inferior oblique, major rectus, inferior oblique, upward gaze, and superior oblique, downward gaze, major rectus, adduction, lateral rectus, abduction, superior rectus, upward gaze in the lateral position, and the inferior rectus, downward gaze in the lateral position. So if there is a third cranial nerve palsy, what will happen? All the muscles are paralyzed except the lateral rectus and superior oblique. Because of that, the patient will have ptosis and the eye directed downward and out because of the action of lateral rectus, and the downward because of superior oblique. This is also demonstration of the oculomotor nerve palsy, which shows the ptosis in left eye, which is showing the ptosis, mydriasis, because also the oculomotor supplies the pupillary constrictor muscle, mydriasis, and the eye directed down and out because of lateral rectus and superior oblique action. As we said, trochlear is supplied superior oblique only, which is responsible for downward gaze in adduction position. Abducent nerve is supplying lateral rectus muscle, which directs the eye to the abduction. Because this nerve emerge near the bottom of the brain, yani near the brain stem, the bottom to the near the bottom, it is often first nerve compressed when there is any rise in intracranial pressure. Different presentation of the condition or association with other condition can help to localize the site of the lesion. Because it's a long pathway, it is easily affected by anything. Because of that, it is a non-localizing sign, and we must see the other associated symptoms to differentiate where is the lesion. Regarding the causes of sixth nerve palsy, the most common cause is the vasculopathy. In case of diabetes, hypertension, atherosclerosis. Also trauma, any head trauma which can lead to lesion of the abducent nerve. Maybe idiopathic without any cause. Yani we search about any cause, but no, so we will say it is idiopathic. Less common causes is increased intracranial pressure. In case of giant cell arteritis, cavernous sinus mass like meningioma, brain stem glioblastoma, aneurysm, or metastasis. Also, maybe in case of multiple sclerosis, it is an autoimmune demyelinating disease, sarcoidosis, which is making vasculitis, post-myelography or lumbar puncture, post-lumbar puncture, sometimes abducent affected, also stroke, but it will be associated with other signs. Maybe also because of the other causes. Chiari malformation is a congenital malformation downward of the tonsil or cerebellar tonsil. It's a congenital deformity. Hydrocephalus, obstructive hydrocephalus, or any cause of intracranial hypertension, and also tuberculous meningitis, inflammation of the meninges by tuberculosis. This is a case of left abducent nerve palsy, which the patient in the right eye directed the eye to the lateral rectus abduction, but the left eye cannot abduction, but this left eye cannot abduct at all, so it is have complete abducent nerve palsy. This is same case, also left abducent nerve palsy, the left eye cannot abduct. The type of sixth nerve palsy is two types, total palsy or partial palsy. Total palsy means paralysis, yani complete muscle weakness, or partial palsy paresis, yani partial weakness. In case of the total palsy, failure of abduction past the midline, yani the eye is in the middle and they cannot move to the lateral to the abduction at all, no movement at all. In case of partial palsy, the presence of abduction, there is presence of abduction across the midline but not reach full abduction. Yani the rim, always there is a rim of sclera is visible on the lateral gaze because no full abduction. Regarding the management of the sixth nerve palsy, the first aim of management should be to identify and treat the cause of the condition, yani the etiology. Where is this possible? And to relieve the patient's symptoms, because in that case the patient will have squint and blurred vision. Because of that, we must relieve the patient's symptoms. In case of children, which is very frequent, they are not complaining of diplopia because they are not, they cannot express themselves. Because of that, they cannot express, they have diplopia or blurred vision, they will not express. The aim will be to maintain binocular vision and thus promote proper visual development. Treatment therapies in children include alternating patch, the patch covers the eye, each one alternately maybe 1 hour, this 1 hour, and this 1 hour to prevent blurred vision, because when they open both eyes they have blurred vision. But in this case, if I cover one eye, it will no blurred vision. Maybe also prism therapy, or sometimes needs trapezius surgery. We will speak this. We finish the third, fourth, sixth nerve. We will speak about trigeminal nerve. Trigeminal nerve is responsible for sensory and motor function, and also supply reflexes. Regarding the sensory branches or the sensory function. It's supply pain, touch, and temperature to the face. This is the three branches. The V1 is the ophthalmic branch, the V2 is the maxillary one, and the V3 is the mandibular one. This is the sensory branches. This is a picture to how to examine, as we said, pain, touch, and temperature. Pain by pain prick, touch by piece of cotton, and temperature by test tube with cold or hot water. Regarding motor branches, the trigeminal nerve are distributed and supplied muscles of mastications. What is the muscles of mastication? Masseter, temporalis, medial, and lateral pterygoid. How to test? So simply, if I need to examine masseter and temporalis, I put the finger, my index and thumb finger, the index over the temporalis and the thumb over the masseter, and ask the patient to clenching the teeth. Then release and clenching again. And what I can test now, I feel the bulk of the muscle, how to contract the muscle contraction, the temporalis and the masseter. Regarding medial and lateral pterygoid, side to side movement of the patient, side to side movement of the jaw. Okay. Corneal reflex is very important. The ophthalmic branch, as we said, there is the ophthalmic branch. I will show again. This is the ophthalmic, V1 is the ophthalmic branch again. So, the afferent of the corneal reflex is the ophthalmic branch of the trigeminal nerve, sensory part. And the efferent is the motor part is the facial nerve. Because what? Corneal reflex, how to test? We put, ask the patient to look forward, and I bring a clean piece of cotton and try to touch the cornea from the side of the patient. Patient look forward, and I am touching the cornea from side of the patient. What will happen? It will be reflex, bilateral eye blinking reflex from the right or the left. As we said, ophthalmic branch of the of trigeminal is the afferent, and the efferent is the facial nerve. This is how to test the motor, as we said, clenching the teeth, side to side movement. Also, there is jaw jerk. How to test the jaw jerk? We ask the patient to midway open the jaw jerk, the mouth midway, and I will put my thumb and my hammer on my thumb. I will tap my hammer over the thumb. What will happen? Normally, it is absent or just elicited. No movement, or maybe a slight movement, which only I feel because I put my finger, but I cannot see. But if this is the normal, just normal, absent or just elicited. If it is increased, the movement when I tap like that on the jaw by my hammer, what will happen? It is exaggerated, increased the closure, which is called exaggerated jaw jerk. This means there is upper motor neural lesion, which called example pseudobulbar palsy. What is the pseudobulbar palsy? Bilateral, pyramidal, above level of bones. Why bilateral? Because the trigeminal, all cranial nerves are bilaterally supplied, except facial have a special consideration. We will speak about it later. But all cranial nerve bilaterally supplied by corticonuclear. So if to have jaw jerk exaggerated, must be bilateral lesion to lose the function. Because the pyramidal is inhibitory to reflexes. Because of that, if there is lesion in the corticobulbar or corticonuclear, it will increase the reflex. Because of that, must be bilateral. And why above the bones? Because must be before innervating the nerve, the cranial nerve, and the trigeminal is in the bones. Okay, we will speak about trigeminal neuralgia. What is the trigeminal neuralgia? It's one of the most common causes of facial pain, hemifacial pain, maybe right or left. the epidemiology, it is most frequently seen neuralgia in the elderly. It usually starts between age 50 and 60, but maybe younger than that or older than that, but this is the usual. Female more affected than male. It is etiology. Regarding the etiology, it is classified to classic trigeminal neuralgia and secondary or symptomatic trigeminal neuralgia. Classic trigeminal neuralgia include idiopathic trigeminal neuralgia cases and those related to vascular compression. Compression by an apparent lobe of an artery or vein. As we said, trigeminal also is in the bones. Because of that, there is a nerve and vascular supply to the bones. Sometimes there is a vascular loop, which is the artery or vein turn around the nerve. This sometimes. So in this case, there is vascular with aging. Start to be vascular compression, and it will compress on the nerve, making symptoms. This is what is meant by compression by apparent loop of an artery or vein. Secondary or symptomatic trigeminal neuralgia is reserved for patients caused by structural lesion, other than vascular compression, as we said in classic type. This means structure means maybe inflammation, maybe vascular, maybe demyelinating, maybe post-herpetic, maybe space occupying lesion. This means why secondary. And this is a symptom. In this case, it is a trigeminal neuralgia is a symptom or apart from this disease. Clinical features. Trigeminal neuralgia is defined clinically by paroxysmal stereotyped attacks of usually intense, very intense, sharp, superficial, or stabbing pain, unilateral in the distribution of one or more branches of the fifth cranial nerve. As we said, ophthalmic, maxillary, or mandibular may be one or more branch. It may be restricted to ophthalmic only, may be maxillary only, may be mandibular only, or may be more than branches, ophthalmic and maxillary and mandibular, like that. And the pain is of that distribution. The pain, the most characteristic is the pain occur in paroxysm and is described always electric shock-like or stabbing pain. This is by patient complaint. Electric shock-like or stabbing. Duration may be several seconds, may occur repetitively, may occur spontaneous repetitive second with repetition. Some patients with long-standing condition of trigeminal neuralgia, it have chronic pain in between this paroxysmal pain. In case of, but it will be dull aching in nature. In chronic long-standing cases, they have the paroxysm of this sharp lancinating electric light, but also in between the attacks, he have a dull pain because of the chronicity. It is typically unilateral, very rare to have bilateral. The distribution of pain, as we said, restrict to the distribution of the sensory branches of the trigeminal nerve, ophthalmic, maxillary, or mandibular. But the most common to involve is the maxillary and mandibular. And why this is the common? Because these always maxillary and mandibular are innervating the maxillary and jaw when are making any dental process or dental problem. It may makes inflammation of this nerve and making be trigger this procedure in the teeth may trigger or precipitate the inflammation of the trigeminal nerve. Because of that, maxillary and mandibular is the most common. The trigger zone of the distribution of the affected nerves, there is always trigger zone. What means of trigger zone? When I touch this trigger zone, it includes just light touch, it will precipitate the paroxysm or the pain. In case of maxillary and mandibular, by showing, talking, brushing the teeth, cold air, exposure to cold air, smiling or grimacing. Most often the condition tend to wax and wane, means in severity and frequency. And sometimes the patient feel it is very improved and no symptoms at all, and sometimes it will be severe and frequent like that. So it wax and wane when in severity and frequency of pain exacerbation. Diagnosis, how to diagnose? The diagnosis is based mainly on the characteristic clinical feature as we described. But to know the etiology, it is classic one or the secondary one, must make imaging. Neuroimaging by magnetic resonance imaging to the brain, and magnetic resonance angiography, MRA, may be useful for identifying, as we said, sometimes there is vascular loop. Magnetic resonance angiography, this is imaging which showing the arteries. We give IV contrast and to visualize the arteries and veins. Because of that, we can to visualize arteries. Because of that, I can know if there is vascular loop or no. Also, the MRI showing if there is MS or basic Q1 lesion, which causes of secondary type of trigeminal neuralgia. How to treat? Pharmacological therapy is the initial treatment of classic trigeminal neuralgia. There is pharmacological, and sometimes we need surgery in certain cases, in cases of refractory types. In case of pharmacological type therapy, it will be, we start by anti-epileptic drugs, starting by small dose and gradually increase till the pain is controlled. Yani not give full dose from the start, give low and go slow. Yani gradually increase until the patient pain is resolved. What is the example of this pharmacological therapy? Carbamazepine, oxcarbazepine, gabapentin, and pregabalin. Regarding the antidepressant, also we use antiepileptic and antidepressant. And what we use, tricyclic antidepressant like amitriptyline, and selective serotonin reuptake inhibitor like duloxetine. This is also treatment of the cause is very important. We said there is a classic, which is primary, which is maybe idiopathic or because of vascular compression, or maybe secondary because of multiple sclerosis, basic Q1 lesion, whatever. Because of that, if we have secondary type, we must treat the cause. In cases of secondary, as we said, surgery, as this is the pharmacological. If need surgery, surgery is reserved for patients who are refractory to medical treatment and not responding. In this case, we go to surgery. We will ask a question about what we said already in the lecture. A 64-year-old female presenting with acute attacks of pain in the left side of the face, electric-like, of few second duration. Attacks are very frequent, 10 to 30 attacks per day. What is the possible diagnosis? Atypical migraine, temporal arteritis, trigeminal neuralgia, glossopharyngeal neuralgia. You will answer by in your. Okay, we will speak to on the next one is the facial nerve, the seventh cranial nerve. The facial nerve supply mainly motor. It is mainly motor and secretory. Motor to the facial muscles. The upper face, which is supplies the innervation of the muscles of the upper face and lower face. The upper face is the orbicularis oculi muscle, frontalis, and corrugator muscle. The lower face, zygomaticus, which is showing the teeth, buccinator, and orbicularis oris, to whisper or to whistle. Okay, this is the muscle, and there is also platysma muscle. Maybe in because I am dressed hijab, yani I cannot show you, but the platysma is in the neck. When the boys or try to shave, they stretch the neck. This is the platysma muscle. These are the muscles which supplied by the facial nerve. And as we said, there is upper face and lower face. Also, it gives branches to greater superficial petrosal, provide parasympathetic innervation to lacrimal gland, sphenoid sinus, frontal sinus, maxillary sinus, ethmoid sinus, nasal cavity, as well as special sensory taste fiber to palate via the vagal nerve. Nerve to stapedius, this is a motor innervation for stapedius muscle in the middle ear, and also it gives secretory to the chorda secretory branch or tasting branch, chorda tympani, which supplies the taste of anterior to third of the tongue. The facial gives the anterior to third of the tongue by chorda tympani, and the posterior taste of the tongue by the glossopharyngeal nerve, the ninth nerve. Okay. When we examine the facial nerve, it must inspect if there is any asymmetry of the face, if there is deviation of the face. All the cranial nerve, when have deviation, it will be toward the affected side, except facial and vagus. The deviation will be toward the healthy side. Because of that, if I have deviation mouth to the left, this means the problem in the right. So I will inspect the face to any asymmetry. It will be have nasolabial fold if symmetrical bilateral. If there is mouth deviation, and the mouth deviation will be towards the healthy side, and must compare between, always by comparison, yani by examination, the facial muscles must be compared. The comparison is the most important. Also, it is, as we said, in the trigeminal, the afferent is the ophthalmic branch of the corneal reflex is the afferent. The afferent is the ophthalmic branch of the trigeminal nerve, and the efferent is the facial nerve, which making blinking of the eye. Because of that, if I try to examine the facial nerve, I must examine the motor part, examine the secretory part, the taste of the anterior to third of the tongue, and also the corneal reflex. We divided the facial nerve to two lesions, the lesion of that facial nerve to two types, upper motor neuron type and lower motor neuron type. Upper motor neuron type, the lesion is in from the cortex until before the reaching the cranial nerve, the brain stem. The facial is in the bones. So any lesion from the cortex until before reaching the bones, the brain stem facial nerve nuclei in the bones, it is called upper motor neuron facial. So it must be from the, it is called corticonuclear or corticobulbar. What is the corticonuclear or corticobulbar? From the cortex to the nuclei, and bulbar because bulbar means bulbar symptom, dysphagia, dysarthria. So because of that, the cranial nerve supply head and neck and making dysarthria, dysphagia when there is a problem. Because of that, we said it is corticobulbar pathway or corticonuclear. So the lesion upper motor from the cortex and before reaching the bones, the brain stem nuclei in the bones. So it is called upper motor neuron type. The upper face will be preserved, and the lower face only is affected by facial muscles. Deviation of mouth, as we said, towards the healthy side. Emotional expression means when I ask the patient to laugh, there is two kind of emotional expression: voluntary emotional expression and involuntary emotional expression. Voluntary, when I see someone and try to make smile for him like that, this is voluntary. But when I hear a joke, I laugh without thinking, so it is involuntary. This is called having emotion. This expression is bilaterally supplied from the frontal lobe, coming from the frontal lobe to the cranial nerve of the facial muscles. Because of that, facial expression or emotional expression, when I told the patient a joke, lead to, and he is laughing, this laughing will improve the deviation of the mouth. In this case, in upper motor neuron facial. If associated with stroke or hemiparesis, it will be on the same side of the facial weakness. Yani, if the facial is right, it will be the weakness on the same side, right side. This is in case of upper motor neuron fissure. Regarding lower motor neuron fissure, the lesion from, as we said before, upper motor from the cortex until before reaching nuclei. Lower motor neuron from the nuclei until reach the facial muscle. If there is lesion from the nuclei in the bones till the facial muscles, it is called lower motor neuron fissure. In this condition, the upper face and lower face will be affected. Emotional expression, as we said, if I told the patient joke, it will laugh, and in this case, in upper motor improve the deviation of the mouth. In this case, it will increase the deviation of the mouth. If associated with hemiparesis regarding strokes, whatever it is, hemorrhagic or ischemic, the hemiparesis will be on the opposite side or on the contralateral side of the facial weakness. Yani it will be, if the patient have right lower motor neuron fissure, it will have left hemiplegia. It is called crossed hemiplegia. I will explain to you why this upper face and lower face. Nucleus of the facial nerve, the upper part of the nucleus supplies the upper face. As we said, the orbicularis oculi, frontalis, and corrugator muscle. This upper part is bilaterally supplied as we said, all cranial nerves are bilaterally supplied, have corticonuclear from both sides, except facial, because upper part only, like other cranial nerve, have bilateral supply. Because of that, if there is lesion in one side, it will compensate by other. Because of that, in case of upper motor neuron fissure, the lower face only affected and the upper face will be preserved. The lower part of the nucleus is supplied by one side, corticonuclear, and also it comes from the contralateral side. Yani if it is the right nuclei, it will have the corticonuclear from the left. Because of that, if there is lesion in the lower motor neuron, it have all the face, affect upper and lower face. Because the lesion, it will be from the bones, nuclei, or until along the pathway until reach to the facial muscles. Also, this again showing what is the difference between upper motor or lower motor and where is the lesion. And if we now will speak localization, how to localize upper motor neuron facial affection. Yani if the facial nerve have upper motor, it have localization. There may be cortical lesion. It will, if it is cortical, will be associated with certain symptoms like Jacksonian motor fits, these epileptic fits involving the face, or aphasia, this is speech disorders, expressive or receptive disorder. If it is the lesion subcortical, it will be no seizures, no Jacksonian motor fits, no aphasia, or aphasia, but it will have facial and monoparesis in the upper limb only. Capsular lesion, the lesion will be on the at the internal capsule. It will have complete hemiplegia. Complete means affect upper limb and lower limb. One side may be right or left. Hemiplegia means right or right upper limb and lower limb, or left upper limb and lower limb. And it will be on the same side of the fascia. Yani upper motor neuron fascia on right side, it will be the weakness of the upper limb and lower limb on the same side. In case of lower motor neuron fascial localization, if the lesion in the bones may be vascular, like ischemic or hemorrhagic, the hemiplegia, it will be on the contralateral side of the fascia. Yani the fascial, it will be ipsilateral to the lesion. Yani if it is upper right, it will be right lower motor neuron fascial. But the contralateral hemiplegia. Why the contralateral? Because of the corticonuclear send directly to the cranial nerve, but the corticospinal the pyramidal tract, which supplies the spine, it decussates at lower end of the medulla. Because of that, the right one, if there is lesion right, it will give left hemiparesis. If it is in left, it will be right hemiparesis. This case of lower motor neuron fascial, the hemiplegia, it will be on the contralateral side of the fascial, and the fascial will be ipsilateral to the lesion and to the presentation. Other cranial nerve may be involved because, as we said, it's in bones, maybe fifth nerve affected, maybe sixth nerve affected. At cerebellopontine angle tumor, the lesion is at cerebellopontine angle tumor, like example, as it may be space occupying lesion or tumor, it will be associated with eighth nerve affection also. It will have deafness. The patient have facial, lower motor, and deafness, and also cerebellar manifestation. In the facial canal, maybe have cholestatoma, aquastic neuroma, otitis media. Loss, it will be the manifestation, loss of lacrimation because of greater superficial petrosal, dry eye, loss of taste of sensation of anterior two-thirds of the tongue, if the lesion before the joining of the chorda, يعني before giving, if the lesion before giving the chorda tympani branch, which supplies the anterior two-thirds of the tongue, it will have loss of this taste. If it is after, it will be preserved. Also, the patient will suffer from hyperacusis because of styloid muscle in the inner ear. It will be paralyzed, so the patient will be sensitive to loud voice intolerance, or hyperacusis. If the lesion adds stylomastoid foramen, it causes Bell's palsy or mastocytis. The cause etiology may be Bell's palsy or mastocytis. The facial lower motor neuron only for muscles only, yani facial muscles only. No affection to greater superficial petrosal, no affection to the chorda tympani. It will be motor only, to motor muscles. And it will be associated with retroauricular pain. Outside the stylomastoid, maybe outside after cross, and it will give only the branches, maybe having parotid. Parotid is here, the anatomical site of the parotid. May have a parotid problem like space occupying lesion, or trauma, maybe someone hitting this area, or surgery, maybe making surgery in parotid gland and leading to lesion during the surgery. It will be partial lower motor neuron affection according to the branches affected. Maybe one muscle, maybe orbicularis oculi only, maybe frontalis only, maybe orbicularis oris, maybe zygomaticus, according to the branch affected of the motor muscles. Okay. What is the Bell's palsy? It is Bell's palsy means facial motor affection only. It will be of acute onset, always unilateral, maybe sometimes bilateral, but always common is unilateral. Approximately 60% of patients have preceding viral illness, maybe herpes simplex. Numbness or pain in front or behind the ear in present in about 50% pre or post auricular pain of patient. 25% may be having impaired taste perception, as we said, anterior two-thirds of the tongue. 10% is less or significant decrease of ipsilateral tearing, maybe decrease of lacrimation. Recurrent Bell's palsy is uncommon. Yani to have, it will be, can be to have recurrent, but it is uncommon. Impairment of voluntary movement of facial nerve and platysma muscle. As we said, platysma in the neck as during shaving, as we said in boys. This will be affected. It will affect all the muscles, and it will be of lower motor neuron type. And it will no evidence of disease of central nervous system, ear or posterior fossa, to exclude localization. These only facial muscles only, and no other associated symptoms. To say it is Bell's palsy. The history should include a careful assessment of the following: recent accident or blow to the head because of parotid trauma, as we said, recent viral infection like herpes simplex, pain behind the ear, pre or post auricular, recent immunization. Also, if there is change in auditory acuity, as we said, it will have hyperacusis in stylomastoid paralysis, may be associated with vertigo if there is vestibular affection, change in the taste. We must ask about all of these. Past and present history of malignancy or HIV, because the patient may be immunocompromised and having susception to have Bell's palsy. The etiology, the main etiologic agent is the herpes simplex type 1. Differential diagnosis, other causes of lower motor neuron facial palsy, as we said, may be infection of the middle ear or mastoid, cholesteatoma, diabetes mellitus, like that. How to diagnose? Diagnostic workup. Electrophysiological study. We do nerve conduction and the EMG electromyogram to the facial muscles. This is a diagnostic and prognostic, because there is two types of the nerve affection. Maybe axonal to the axon of the nerve, or maybe demyelinating or the myelin of the nerve. The myelin, if it is demyelinating, it is for better prognosis. If it is axonal, it is worse, mostly worse, and take more time in prognosis and the recovery. Because of that, it gives us confirm our diagnosis and give us how to assess prognosis and recovery, because as we said, if it is axonal, it means it is slow recovery and maybe worse prognosis, and if it is demyelinating, it is better recovery and prognosis. We do also the imaging, CT, MRI, to detect the lesion causing lower motor neuron facial palsy, to know if there is secondary causes. Laboratory test, CBC, fasting blood sugar, postprandial, ESR, all routine to exclude maybe associated with diabetic, because the most common cause of the Bell's palsy, it may be associated with diabetes. Prognosis and complication. Full recovery occurs in most of the patient. As we said, the recovery may be 4 to 6 months, depend on it is demyelinating or axonal. Early complication is related to the eye, like conjunctivitis, because the patient in complete closure to the eye, and it will suffer from something called Bell's phenomena. When try to close the eye upward gaze. So it is called Bell's phenomena and incomplete closure of the eye. Because of that, if we cannot care about it, it will lead to conjunctivitis, keratitis, and exposure corneal ulcer. And the exposure corneal ulcer is the most dangerous complication, can be seen in facial nerve, in Bell's palsy. Because of that, we must care, very, very care about the eye during management. Late complication, like contracture, is the most common late complication, contraction of the muscles itself. It will be fibrosis of the nerve, may require sometimes plastic surgical correction if severe. May also something called gustatory or crocodile tearing. When the patient chewing or eating, the tears come off from the eye, because of there is when re-innervation occurs, there are regeneration of the secretory fibers associated with the mastication. So the patient, when masticate or chewing or eating, the lacrimation occurs. Also, one of the complications is facial myokemia or hemifacial spasm. The patient have muscle twitches like that, which is a complication of the facial nerve. We will speak about management, how to manage facial palsy or Bell's palsy. First, as we said, eye care. This is very, very important. It is a primary concern in Bell's palsy. As we said, because of the most dangerous complication, the patient to have exposure keratitis or corneal, the most dangerous is the corneal ulceration. Because of that, we must care, give lubricating eye drops during the day and all over the day, and ointment like petroleum at night are usually effective, and sometimes ask the patient to cover the eye with patch if it is severe incomplete closure. Also, we give prednisone, only cortisone, only given within the first 5 days at a dose of 1 milligram per kg prednisone per day, up to 60 milligram for 7 days, then gradual withdrawal. cortisone must be gradually withdrawn. If give this, it will be gradual titration. Acyclovir may be of value in the early stages of Bell's palsy because it is of viral series, so we give acyclovir in first week only. Physiotherapy is very, very important. What means by physiotherapy? To keep the patient making phradic stimulation, massages, treatment. Ask the patient always to blow, to close the eye, to massage, and making ultrasonographic laser phradic stimulation for the muscles, because that the facial nerve is innervating the facial muscle. If it is problem in the nerve, the muscle will not act. Because of that, if I ignore or neglect, and the patient may be 2 months or 3 months to be recovered, the muscles after that may be recovered of the nerve, the muscles will be affected because disuse. We have something called disuse atrophy. If we not use the muscle, it will be disused, it will be atrophied. Because of that, physiotherapy is very important to keep facial muscles function and to prevent disuse atrophy. Clinical facial nerve test, how to test, we will speak about facial movement. As in this picture, the patient ask the patient to raise the eyebrow, this frontalis muscle, and to compare the wrinkle on both sides. Ask the patient to close the eye forcefully and can try to open against the resistance. Ask the patient to showing the teeth, blow, cheek, and cervical grimacing for cervical platysma muscle. This is the how to examine. This is a picture showing that the right one showing upper motor neuron lesion. There is deviation of mouth towards the left. This means there is right upper motor neuron, and the nasolabial fold is flattened on the right, and but the patient can close the eye very nicely. So it lower face only affected. So because of that, we said upper motor neuron lesion. In the left one, lower motor neuron lesion, because the patient deviation to also on the right side, deviation of the mouth to the left, because the deviation is lower the healthy side, and the patient he can close left eye, but he cannot close at all the right eye, means there is upper face and lower face affected. This means lower motor neuron lesion on the right side, and this one right upper motor neuron lesion on the right side. This also a demonstrated diagram or a figure to show loss of forehead, as we said, brow and eyebrow movement, inability to close the eyes, dropping of eyelid, loss of nasolabial fold, and deviation of mouth to the health side. So the patient have left lower motor neuron fissure. In this case, this young man showing incomplete closure to the eye to the left, deviation of mouth to the right, so the patient upper face involved and lower face involved, the patient have left lower motor neuron fissure. We will speak what most dangerous complication of the Bell's palsy: delayed recovery, faulty re-innervation, corneal ulcer, or residual facial weakness. Okay, we will speak about vestibulocochlear nerve. It have two. It's the eighth nerve. It have two components: vestibular type and the cochlear type. Vestibular means balance, or responsible for equilibrium and balance information from the inner ear, and the cochlear is responsible for hearing. So it is two parts: balance and hearing. Here we have to examine by rubbing fingers near to the ear of the patient and to compare. Rubbing fingers here, and to compare. This is rough method to be sophisticated, and if I suspect there is a decrease in acuity, a decrease in auditory problem, I must send to ENT and doing the specialized sophisticated test, Weber test, Rene test, and if indicated, look to external auditory canal and eardrums. But I will send to the ENT if I found any problem regarding to do sophisticated tests and even audiometry. But roughly, if the patient have no problem, just rubbing the finger near the ear of the patient and compare between two. This is the vestibulocochlear. As we said, this is the auditory part. The vestibular, the component of balance, or the balance or equilibrium part by the test of equilibrium to do finger to finger, finger to nose, patient steady gait, if it is ataxic or not, with closure of eye or open the eye. Because of that, vestibulocochlear is very important. We go to ninth cranial nerve, glossopharyngeal nerve. The glossopharyngeal nerve supplies the posterior pharyngeal wall and gives the taste of the posterior 1/3 of the tongue. As we said, facial gives you anterior 2/3 of the tongue taste, and the glossopharyngeal gives the posterior 1/3. And also it is the afferent of the gag reflex. The afferent is the gag of the gag reflex is glossopharyngeal, and the efferent is the vagus. Vagus supply the, because of that we must test 9th and 10th nerve together. The patient by showing examine the speech or of the patient, have hoarse or nasal voice. Ask the patient to swallow if there is any problem regarding the swallowing, having dysphagia. Examine the palate and uvular displacement. I will see the uvula central or not and movable or not by saying the patient say ah and show the uvula it is central or not and movable or not. And as we said, gag reflex, stimulate back of throat, each side, posterior pharyngeal wall. The patient will say يعني he tend to, we will not let him vomit, but يعني by irritation he try to vomit or say gag, which is the primary to vomit, يعني not reach vomiting. The gag reflex, the afferent is the glossopharyngeal and the efferent is the vagus. If there is a problem, it may be normal, or if it may be 9th or 10th affection, may be increased or decreased. Decreased, absent gag reflex may be lesion in the brain stem regarding 9th or 12th, 10th nerve, or maybe the gag reflex is exaggerated. Whenever the gag reflex is exaggerated in case of pseudobulbar. As we said, pseudobulbar, bilateral pyramidal above level of bones, means the lesion of the cortex, corticonuclear lesion, also which supplies the gag reflex. It inhibits the gag reflex. If there is lesion bilateral, it will lead to exaggerated gag reflex and dysphagia. The vagus nerve, it supply motor, also supply parasympathetic fibers to all the organs except supraadrenal gland, from the neck down to second segment of the transverse colon. So it is give parasympathetic supply to all organs except the adrenal gland. That the uvula, as we said, must be central and movable in gag reflex, and if there is deviation, it will be deviated towards the healthy side as facial. As we said, cranial nerve lesion, the deviation to the healthy side, to the affected side, except facial and vagus, vagus nerve. It will be towards the healthy side. So if the uvula is having right vagus lesion, the uvula will deviate to the left. In case of spinal accessory nerve, it is the 11th nerve, which supplies the sternocleidomastoid muscle and trapezius muscle. The sternomastoid muscle, it is only motor for sternomastoid and trapezius. The sternomastoid, when I want to deviate the neck to the left, the right one, I test right sternomastoid. If I want to test left sternomastoid, ask the patient to look to the right and palpate the left sternomastoid muscle. Regarding trapezius, shrugging the shoulder, I try to make the patient in front of me, and the examiner will be behind the patient, and inspect if there is any trapezius abnormality, and ask the patient to shrug the shoulder as in this picture. The examiner behind the patient and ask him to shrug the shoulder against resistance. And as we said, the sternomastoid, if I test right, I will ask him to look to the left, and if I try to palpate the left, I ask him to look to the right against resistance. We will go to last one, hypoglossal nerve. It is the 12th nerve, which is pure motor to the tongue muscles. It supplies motor fibers to all muscles of the tongue except the platoglossus muscle, which is innervated by the vagus nerve, according to some classification by fibers from glossopharyngeal nerve sometimes. But the hypoglossal supply all muscles except the platoglossus muscle. To test the function of the nerve, the person is asked to protrude the tongue outside and inspect if there is any involuntary movement, if there is wasting, if there is deviation of the tongue, and the deviation, it will be towards the affected side. Okay, as we said, all cranial nerves towards the affected side except facial and vagus towards the healthy side. The tongue will deviate towards the affected side. The strength of the tongue is tested how? By doing like this. I ask the patient to poke the tongue against the cheek. Poke the tongue against the cheek, and I will resist from outside and compare both sides if it is equal or not. This is how to test the power of the tongue. As we said, we must protrude the tongue, showing if there is involuntary movement. What is the involuntary movement? Involves the tongue, fasciculation, chorea, and tremor. If there is wasting or not, and if there is deviation or not, and the deviation will be towards the affected side. And this is a picture showing that the tongue is deviated to the left, and there is wasting of the tongue toward left side of the tongue. So it have left hypoglossal lower motor neuron type. Okay, we will ask 3 questions. In a patient with left upper motor neuron facial, on examination of the corneal reflex on the right side, touching the right cornea with a piece of cotton will produce blinking in both eyes, no blink in either eyes, blink on right side only, blink on left side only. Which of the following muscles is not innervated by the oculomotor nerve? Superior rectus, inferior rectus, lateral rectus, or inferior oblique? Which of the following cranial nerve would most likely be affected in patient presenting to you with papilledema, headache, and significant obstructive hydrocephalus? Which affected nerve? Facial nerve, trochlear nerve, abducens nerve, or trigeminal nerve? Okay, thank you.